Good morning, everybody. You all are welcome to the CME lecture series of Cancer Society of Medicine. This is the first lecture after a wonderful annual academic session of Cancer Society of Medicine. Today, I'm going to introduce not a new person to the PG trainees and medical students. He's Dr. Chamara Dalugama, not to everybody. He's the product of Peradeniya Medical Faculty of Medicine, University of Peradeniya. He has got the wonderful and outstanding medical student career. He got his MBBS in 2013 and with the rank first in the common merit list and first class in second MD, third MD, and final. Got his MD in 2019 and he got during the medical student period, and he was distinction in almost all the subjects. I'm really proud of you, Chamara. And awards and scholarships and gold medal. He got about 27 gold medals, and he's really proud to the Peradeniya medical faculty. And he got his MD, post-MD training in Oxford University Hospital, UK, in acute medicine. And many publications, and a big list of many publications and local and international publications. And he currently working as the honorary consultant physician and specialist in internal medicine in Teaching Hospital Peradeniya and senior lecturer in Faculty of Medicine, University of Peradeniya. He's going to talk about hypertension practice in essentials. Chamara, over to you.
Okay, very good morning to you all. And first of all, I would like to thank the Cancer Society of Medicine for giving me this opportunity to talk to you, as well as Dr. Nandana for that generous introduction. So today the talk will be on a very important and a timely topic. So it is about hypertension, and today what I'm going to discuss is mainly the practice essentials as doctors and a lot of medical students in the audience as well. So basically what to do when you see a patient with hypertension, right? So for the next 45 minutes, the basic outline of the talk would be where I will be briefly discussing about the global and Sri Lankan situation and the burden of hypertension and the presentation of hypertension and how to make a diagnosis, the workup, and when to start treatment and what to start for treatment. Right. So talking about the global burden, so if you can see this map, it depicts the prevalences of hypertension. You see the most of the Asian countries, the Africa and the South America, they carry a very high prevalence, which is ranging from 25% up to 35%. So if you take as a whole, the global prevalence is up to 1/3 of the world population, the adult population. And if you compare this map with a map which is 30 years back, a clear change that we see is the prevalence is shifting from high-income countries to low-income countries. So as a developing country, Sri Lanka, we are going to experience this increase in prevalence of hypertension in years and decades to come. Talking about the Sri Lankan situation, this is the latest study that was done where they have looked at the prevalence, predictors and associations of the hypertension in Sri Lanka. The finding of the study is that 1/3 of Sri Lankan adult population is hypertensive. So it is fairly a significant number. And okay, so talking about the burden of hypertension, hypertension is the leading cause of mortality and morbidity worldwide. So if you see here, this is basically a chart which is depicting the deaths attributable to individual risks, right? So if you see this one, hypertension is ranking first, and your diabetes, your overweight, obesity, dyslipidemias, alcohol use, everything is coming behind hypertension. So hypertension is the major leading cause of mortality and morbidity worldwide. So talking about the burden of hypertension, so hypertension is associated with adverse cardiovascular outcome. So it can be either a myocardial infarction, stroke, or peripheral vascular disease. And at the same time, it is associated with adverse renal outcome. So there's a lot of patients who get into end-stage renal failure because of high blood pressure. And it is significantly associated with cognitive decline and dementia. And it is one of the important cause of worldwide blindness. And finally, it is the leading cause of all-cause mortality in the world. So when we talk about the presentation, so this is the important thing. Hypertension is largely asymptomatic. So the initial presentation of hypertension may be with a complication or an incidental finding of a high blood pressure. So what we see commonly is there are so many patients coming to the ward with, say, a myocardial infarction or a stroke or impaired renal functions. Then we make the first ever diagnosis of hypertension. So therefore, hypertension is considered as a silent killer, a killer in disguise. Sometimes there can be other presentations where in secondary hypertension, the patient can have different presentations according to the underlying cause. So, say for instance, a pheochromocytoma, patient may be having hypertension and at the same time, episodic sweating, headache, and palpitations. A Cushing's patient might have hypertension, but he may have symptoms like proximal muscle weakness, easy bruising, or a poor glycemic control. And a muscle weakness due to hypokalemia can be seen in a patient with Crohn's disease. But the secondary hypertension is not the common one. It's the essential hypertension, which is largely asymptomatic. This accounts for around 10% of the patients with hypertension. Now we will define what is hypertension. Although hypertension is very prevalent, we don't have a universally agreed definition on hypertension. There are so many colleges, societies, they have come up with their own definitions. But this is understandable because hypertension is a normal the blood pressure is a normal physiological variable, right? So as you know, these physiological variables are normally distributed in a population. So if you take normal 100 people, normal people, say 100 people, if you plot the hypertension, it will follow the normal Gaussian distribution. So we can't give an exact value, okay? Look here, above this value, we can consider you as hypertensive. Therefore, the definition is based on this argument, where the blood pressure level at which the intervention improves the outcome or the benefits outweigh the risks is defined as hypertension. So arbitrarily, different colleges have come to an agreement that the blood pressure in the clinic or in the office, if it is more than 140, the systolic blood pressure, and the diastolic blood pressure more than 90, in repeated measurements, we will consider as hypertension. So that is the current agreed definition of hypertension. So to make a diagnosis of hypertension, obviously we'll have to measure the blood pressure. So blood pressure measurement is something that we have been doing from our medical student days. But it's important to understand what is the correct technique of blood pressure measurement. So the most important thing is having a validated monitor. So we have these mercury blood pressure meters which have been there in the wards for decades, ages, and sometimes they may not be calibrated for a long period. So the most important thing, even if you purchase a blood pressure meter from outside, it should be a validated blood pressure meter. And the second thing is, within 30 minutes before your blood pressure measurement, you should make sure that the patient has not smoked, not done any strenuous exercise, not had alcohol, or not had any caffeinated beverages, because that is going to have a significant effect on your blood pressure measurement. And then you need to get the patient to sit at least for 5 minutes comfortably on a chair before taking the blood pressure measurement. In practical settings, this may not be always practical, but at least to give you some rest for the patient before the blood pressure measurement. And then you need to select the proper cuff size. And then the blood pressure cuff, like what we commonly do is sometimes with our busy clinic work, we tend to wrap the blood pressure cuff over the clothing. So which again going to have give us erroneous blood pressure reading. So the blood pressure cuff need to be wrapped against the skin, but not over the clothing. And then during your blood pressure measurement, patient should relax and should not be talking. And then the blood pressure, the cuff arm should be resting on a table or a flat surface comfortably and at a level of the heart. And then the patient should be sitting upright with a straight back, and the legs should be uncrossed and the feet should be lying on the floor. Right? So it is not as simple as we think to make a correct blood pressure reading. But after making a blood pressure reading, we are going to make a diagnosis, and this man is going to carry the diagnosis of high blood pressure for the rest of his life. So always make sure that you use the correct technique when you are making a blood pressure measurement. Then this is about the setting of blood pressure monitoring. So one thing is we do measure blood pressure in the clinic, which is called as office blood pressure readings. So usually to make a diagnosis, you need to have repeated measurements of blood pressure in the clinic. And there are two ways that we can measure the blood pressure. One is the attended blood pressure monitoring and the unattended. So attended is simply what we do most of the time. The patient comes, sits by you, and then you take the blood pressure meter and you make a measurement of the blood pressure. And the other thing is, which is commonly used in other countries, as well as in Sri Lanka also, this is sort of used because of this COVID pandemic, where unattended automated office blood pressure, where the patient is given instructions, there is an area where patient goes, sits, relaxes, and then apply the blood pressure cuff, and he by himself or herself get a blood pressure reading. It's usually an automated blood pressure cuff. And this is important because it is useful to eliminate the white coat effect, which we will discuss briefly in a while. And also, where we talk about a lot of social distancing in the COVID era, this would be an ideal way of measuring the blood pressure. And then the out of office blood pressure monitoring, that is, there are two things. One thing is we can do an ambulatory blood pressure monitoring, or we can do a home blood pressure monitoring. So the ambulatory blood pressure monitoring is where we get the patient to wear a blood pressure cuff and get him to do his normal routine activities. So the blood pressure readings are made during the day and night, and when the patient is doing his routine activities during the day. And it will take multiple readings, and actually this is considered as the most accurate and the gold standard way of diagnosing hypertension, because it eliminates a lot of biases. But the problem is, ambulatory blood pressure monitoring is not widely available, and even if it is available in the private sector, it is a bit costly. And the other way is to get a home blood pressure monitoring. But for this purpose also, you will need to have a blood pressure meter at home, and the patient need to be trained. But this is again practical, where the patient can take multiple readings of the blood pressure. Right. Okay. Now what we will discuss. So you are in the clinic and a patient comes to you, right? So what you will do in the first clinic visit. So when you take a blood pressure reading, always make a habit that the first blood pressure reading, you do it in both arms. Because sometimes patients who are having atherosclerotic vascular disease, in one arm the blood pressure may be normal, even low, but in the other hand, he may be carrying a very high blood pressure because of various atherosclerotic diseases involved in the upper limb vessels. So if there is a difference in the arms, take the arm with the higher reading. And if your first blood pressure measurement is more than 135, the systole, and the diastole is 85, take two more readings at least 30 seconds apart. Right? And you can discard the first reading and you can take the average of the second and third reading. So this is the first ever visit of a patient where you check the blood pressure and you find the blood pressure is slightly high. So you check the blood pressure in both arms, and if there is a difference, take the arm with the higher reading. And if the blood pressure is more than 135 by 85, take two more readings, discard the first reading and take the average of the second and third reading. Now we have done that, and this is the blood pressure value you get. So you have a patient where the two blood pressure readings are more than 180 by 100, fairly high readings. The next immediate thing you should consider is whether the patient is in severe pain or distress, or whether there's any physiological cause for this high blood pressure. Sometimes even in the ward setting, you might find previously normotensive patient, but suddenly you read a high blood pressure to see the patient is in severe distress because of, say, a urine retention, or maybe in severe pain. So if that part you need to eliminate. And then with this blood pressure, the next immediate thing you should consider is whether there is any hypertensive emergency. So by definition, hypertensive emergency is where the blood pressure is too high and it causes acute hypertension mediated organ damage. That can be in the form of angina, patient may be in acute heart failure, may be having a stroke, or patient may be having acute kidney injury. So if the patient has an hypertensive emergency, this patient needs admission and a specialist referral. So you check the blood pressure in your office or in your clinic, you eliminate the physiological causes for high blood pressure, and then you see whether there is a hypertensive emergency. Yes, patient needs an admission. But if the patient does not have an hypertensive emergency, not all patients will need admission to control this high blood pressure. So this can be managed at a clinic level, and you can start the treatment. Right. So in the first visit, this is the blood pressure that you get. It's not as high as 180 by 110, but the blood pressure is 130 to 179 and the diastole is 85 to 109. So if the blood pressure is at this level, always you can confirm your diagnosis by 2 to 3 measurements of blood pressure in a couple of occasions, right? So if this is in the clinic level, one thing we can offer is we can get them to come again, maybe the following day or in a nearby day for a repeat blood pressure measurement. Or else we can ask the patient to go to one of the nearby places, nearby practice to get the blood pressure checked. Or in ideal setting, we can arrange an ambulatory blood pressure monitoring or a home blood pressure monitoring for this patient. Because by definition, hypertension, you need to have elevated blood pressure of more than 140 by 90 in repeated occasions, right? Okay, right. Now we will define hypertension. So now your patient has come to the clinic and you have checked the blood pressure. You have confirmed it in repeated measurements that the blood pressure is high. So if the clinic blood pressure is repeatedly more than 140 by 90, you can make a diagnosis of hypertension. And assume that you have arranged an ambulatory blood pressure monitoring for this patient. The patient comes to the clinic, blood pressure say it's 150 by 95. Okay, you don't start treatment because it's not as high as which warrants immediate treatment. So you have arranged an ambulatory blood pressure monitoring. So in the ambulatory blood pressure monitoring, the values are slightly lower than your clinic blood pressure. So the 24 average, if it is more than 130 by 80, you can make a diagnosis of hypertension. And the daytime average, it's 135 by 85, and nighttime average, see the values, it's 120 by 70. So even if the blood pressure is 125 by 75, in a nighttime average of ambulatory blood pressure monitoring, you are going to make a diagnosis of hypertension, right? Because this is important because there are a lot of patients who get the ambulatory blood pressure monitoring done from private sector and they come with a report. And sometimes we see the report, the 24 average is 135 by 85. Then we think, okay, I mean, it's not high. So we tend not to make a diagnosis of hypertension. But remember, these values are lower than the clinic blood pressure values. And if it is home blood pressure monitoring, if the blood pressure readings are repeatedly more than 135 by 85, you make a diagnosis of hypertension. Right. So this is an interesting slide which talks about various blood pressure phenotypes. Right. So here in the x-axis is about the ambulatory blood pressure monitoring or the home blood pressure monitoring. And the y-axis is the office blood pressure monitoring. So your office blood pressure is less than 140/90 and your ambulatory blood pressure is less than 135 by 85. So you can confidently make a diagnosis. This person does not have hypertension. He's normotensive. And your office blood pressure readings are high. And at the same time, your ambulatory blood pressure readings or home blood pressure readings are also high. So this is a clear phenotype of hypertension. But there are two other different phenotypes. So one such phenotype is where in the clinic, you always get a high blood pressure reading. It's 150/95, 160/100. And then you arrange an ambulatory blood pressure monitoring, which is completely normal. So this category is defined as white coat hypertension. Basically, they don't have hypertension, but when they come to a clinic with anxiety and a lot of other white coat effects, you read a high blood pressure reading. And then there's another category which is called masked hypertension. So this is the dangerous category where they come to the clinic, you check the blood pressure is normal. But sometimes you find them when you do a ECG, the ECG shows a bit of a left ventricular hypertrophy. You do an echocardiogram for some reason, the cardiologist comments that there is concentric LVH. Or else the patient has some form of renal impairment. The creatinine is slightly up, there's a bit of a proteinuria in the urine. But you can't find any other explanation why this has happened. So in this sort of a scenario, something to suspect is whether this man is having masked hypertension, where your blood pressure readings in the office is normal, but if you find some evidence for hypertension-mediated organ damage, you can arrange an ambulatory blood pressure or home blood pressure monitoring. And then that will be that in those readings, the patient may be qualifying for a diagnosis of hypertension. So actually 10% of the hypertensives are having masked hypertension. And this is the real killer in this case, because we don't make a diagnosis of hypertension, we don't treat, but they can come with a complication related to hypertension. Okay, fine. Then we will go to the hypertension classification. This is something very familiar to you. So the grade 1 hypertension is where blood pressure is 140 to 159 and diastole is 90 to 99. And grade 3 is where the blood pressure is more than 180 and 110. And you have a normal blood pressure reading which is 120 to 129 and diastole less than 80. And this category, which is called high normal blood pressure or the upper range of normal, where you have a systolic blood pressure between 130 to 140 and a diastole of 80 to 89. Okay, so now we will discuss some patient has come to you, you have correctly checked the blood pressure and you have made the diagnosis of hypertension. So this is the first ever diagnosis of hypertension that you have made in this person. So how would you evaluate this person? So first I will discuss the aims of initial evaluation. Right? The first aim is to see whether this man is having anything suggestive of a secondary cause of hypertension. So your first aim is to exclude or to identify secondary causes of hypertension. The second thing is he's having hypertension and how badly the hypertension has affected his organs. So you have to determine the target organ damage. And thirdly, we always treat a person, not the disease. So if the patient has hypertension, he's at increased risk of having all the other complications related to hypertension. So you have to have an assessment about the total cardiovascular risk of the individual. So the first aim is to exclude or identify secondary causes of hypertension. So there are so many secondary causes. So you are aware of this. There are endocrine causes like acromegaly, thyrotoxicosis, primary hyperaldosteronism, pheochromocytoma, etc. And there are certain renal causes where chronic kidney disease, chronic glomerulonephritis, polycystic kidney disease. And then sometimes obstructive sleep apnea can be a secondary cause for hypertension. And there are a lot of other medications that can give rise to secondary hypertension. Talking about common medications, steroids, use of NSAIDs, oral contraceptive pills, and other medications like cyclosporine, tacrolimus, and various other weight loss agents, various psychiatric medications, and even various recreational drugs such as cocaine and amphetamines can give rise to secondary hypertension. So particularly if your patient is a young patient, less than 35 years, and if the hypertension is difficult to treat, or if the patient is having accelerated hypertension, you need to consider possible secondary causes. And the second aim is to determine what is the target organ damage. So as you know, hypertension can affect almost all the organs in the body. So it can affect the eye, the retina, where you can have hypertensive retinopathy, and it can have adverse effects on the heart, where the patient can develop heart failure, cardiomegaly, various arrhythmias, and can have effect on peripheral arteries, where they can develop peripheral vascular disease, and effects on the kidney, which can be manifested like a renal impairment or proteinuria, and stroke, transient ischemic attacks, or unexplainable dementia can be a target organ damage from the hypertension. So you need to take a detailed history, examination, and investigations to look for the target organ damage. And thirdly, you have to see this person as a whole and what other cardiovascular risk factors the patient is having. So is the patient smoking? Is he a diabetic? Is he a dyslipidemic? Whether the patient has established coronary artery disease, any cardiovascular disease, whether he has renal impairment, and also whether there is a significant family history of premature coronary artery disease. So, in your smartphones, you can get this app which calculates the 10-year atherosclerotic cardiovascular disease risk. It's a simple app where you have to put all these things, and that will calculate the risk of this person having a cardiac event or a cerebrovascular event within next 10-year period. So it will have a lot of implications on the management that we are going to discuss. Right. So these are the broad aims that we will target when we see a hypertensive patient for the first time. What we should be doing. Right? So you have the patient with you, you have made the diagnosis of hypertension. So the first thing is to get a history. Right? So in the history, the important things that you need to focus is you have to look for symptoms suggestive of secondary causes. Right? So we have discussed about the common secondary causes. So we have to ask. And then to get a detailed past medical history, whether the patient has ischemic heart disease, whether the patient has had any renal disease. And then a detailed drug history. So this may be the patient's medication list, as well as patient may be on a lot of over-the-counter medication. Maybe for arthritic condition, he may be taking over-the-counter prednisolone and some NSAIDs, which may be the cause why he has become hypertensive, and a history of smoking, ethanol, and family history. And then the examination, again, I mean, this is again to look for those three things that we aimed, right? To look for secondary causes, to look for target organ damage, and to assess the atherosclerotic cardiovascular disease risk. For examination, the height and weight of the patient to calculate the BMI, see whether the patient is pale or having evidence of heart failure. A focused examination of the cardiovascular system where you look at the pulse, whether there is a radial or radiofemoral delay, JVP, and the character of the apex, whether it is displaced, and whether there are any murmurs or any other evidence of heart failure. And in the abdomen, you just feel the abdomen, see whether there are palatable kidneys or any evidence of renovascular hypertension. And you can look at the patient and see whether he has features of endocrine disease. So patient may be looking cushingoid or acromegalic or thyrotoxic. Or sometimes patient can have neurofibromatosis, which can again be a secondary cause for hypertension. And also have a look at the fundus. So those are the basic examination things that we would do in the first clinic visit to identify a secondary cause of hypertension, to look for the target organ damage, and to get an idea about the atherosclerotic cardiovascular disease risk. And some simple investigation. A urine dip where we look for the protein and red cells, a fasting blood sugar and a lipid profile, a renal profile, looking at the serum electrolytes, transaminases, hemoglobin, and a 12-DCG. So this is not the advanced investigations that we will do to look for a secondary cause, which I am not going to discuss in detail, but in the first visit, in any patient with hypertension, these simple investigations need to be carried out, where it will tell whether the extent of end organ damage as well as other cardiovascular disease the patient is having. And after making a diagnosis and after initial evaluation, you need to set targets in the treatment, right? So your aim is then to treat the patient to achieve these targets. So in every patient with high blood pressure, your target is to have a blood pressure less than 140/90. You may remember that some years back, they said for people who are elderly, maybe more than 80 years, they had a higher target. But now, from 2020, from the International Hypertension Society guidelines, we all target of a blood pressure less than 140/90. And once this target is achieved, then target for even lower value, because for each mercury millimeter you reduce in the blood pressure is shown to improve the overall morbidity and mortality. So if the patient is tolerating a blood pressure of 140/90 without adverse effects due to the medication, you can even target for a lower target, so 138. And particularly in patients who are younger than 8 years, you can further go for a target of systolic blood pressure 120 to 129. But in patients who are more than 8 years, the target is to reduce the systolic blood pressure to 130 to 139 if the patient is tolerating. And always target a diastolic blood pressure less than 80 in all age categories, right? So these targets are realistic, so you have to go step by step, and always you have to weigh the risks and benefits. So we are going to reduce the blood pressure with a lot of antihypertensive medications, with lifestyle changes. So patients should not be having undue side effects, should not be having severe postural hypertension and getting falls. But if the patient is tolerating, now the recommendation is to go for the lowest possible target, particularly in patients younger than 80, to target a systolic blood pressure between 120 to 129. So the treatment. So lifestyle changes for everybody with hypertension, and then pharmacotherapy in selected categories. So what are the lifestyle changes? So this is a very interesting slide, which is taken from the American College of Cardiology 2017 guideline, where they have shown that without any antihypertensive medication, just by the diet alone, you can reduce the systolic blood pressure by 11 mercury millimeters, and cutting down on alcohol by 4 mercury millimeters, and exercise 4 to 8 mercury millimeters. And each kilogram you lose, you can reduce the blood pressure by 1 mercury millimeter. So this is important because if you have grade 1 hypertension, which we will be discussing in a while, and if you don't have any other target organ damage, you can simply adapt lifestyle modifications as the sole treatment and get your blood pressure under control, right? So that is why I mentioned that pharmacotherapy is not in all categories of hypertension. Right, so what are the lifestyle changes? So I'm not going to again talk in detail about the lifestyle changes, but this is something that is shown to reduce your blood pressure significantly, which is called DASH diet. So the DASH stands for dietary approaches to stop hypertension. So in very simple terms, DASH diet is not something that is very difficult to follow. It doesn't involve any expensive dietary recipes, but this is a very simple, heart-friendly way of eating, where we mainly focus about different number of servings from different categories of food. So basically what the DASH diet recommends is that you need to take increase in number of servings of fruits and vegetables. And then you take grains. And then you have lean protein, lean meat and fish. And then you add 4 to 5, number of servings of nuts and seeds. And then you have low fat milk products. And then you cut down on your oil, fats and sweets. And at the same time, the DASH diet recommends taking a lot of the fruits and vegetables, which of course has a lot of potassium, magnesium, and calcium, which is shown to reduce your blood pressure. And at the same time, you cut down on your salt. So the recommendation is to reduce your salt intake to less than 1 teaspoon a day, and if possible, if tolerating, to go for half a teaspoon a day. And this DASH diet, again, as the previous slide, it has shown that 11 mercury millimeter reduction in systolic blood pressure just alone by adapting this type of a diet. And at the same time, they have shown that DASH diet reduces the incidence of or reduces the risk of you getting diabetes, and it promotes weight loss. And at the same time, because the DASH diet has a lot of fruits and vegetables, there's a lot of antioxidants, so there's a significant reduction in cancers. So it has a lot of anti-cancer properties as well. So this is something very simple that we all can adapt to help with our blood pressure. So in addition to the diet, you can have a lot of lifestyle changes such as exercise, where the recommendation is to go for 30 minutes of aerobic exercises per day, which you can practice for 5 days per week, and then cutting down on your alcohol and completely stopping smoking, and also adapting a healthy lifestyle, which is sort of a stress-free lifestyle. So these lifestyle changes they are recommended in each and every patient, and usually when we see hypertensive patients in our clinics or in the wards, we hardly give any recommendation on these things. But now, a lot of people use YouTube and social media. So even if you just write the name the DASH diet and to Google it and see in YouTube, there are so many videos even in Sinhala done by nutritionists and a lot of other healthcare professionals, which give very nice explanations to what exactly it is, and they can simply adapt that practice and help with their blood pressure. Then when we go to talk about pharmacological treatment, you don't start drugs in every patient you make a diagnosis of hypertension. If your initial blood pressure reading is more than 180, 110, obviously you need to start some pharmacotherapy. And if it is more than 160 by 100, that is grade 2 hypertension, you need to start on pharmacotherapy. But if they are in this category, which is called grade 1 hypertension, always look for the following things. And if they are there, you need to start on medications. But if they are not there, you can initially adapt a lifestyle modification strategy to treat it. So we'll take this third category. So you make a diagnosis of hypertension, the blood pressure is say 150 by 95. Then look at the patient, see whether he has got any established cardiovascular disease. So if he had a recent myocardial infarction or a previous stroke, or else the patient has some renal impairment or proteinuria, or there's any other organ damage. ECG may be showing some left ventricle hypertrophy, echo may be showing some concentric LVH, or else the patient is a diabetic. So if your patient with grade 1 hypertension qualifies with one of these conditions, either a MI or a renal impairment or some form of organ damage or diabetes, in your assessment, they will need to be started on pharmacotherapy. But you can consider lifestyle modifications alone in patients with mild hypertension without these hypertension-mediated organ damage. But if you adapt a lifestyle modification strategy, the patient cannot be simply discharged to the community. They need some form of regular follow-up to see what's happening with their blood pressure. Right. So this is again another category where we have not made the diagnosis of hypertension. The blood pressure is in the high normal range. So it's 130 to 139, diastole is 80 to 89, but they have established coronary artery disease. So this may be a patient who had a recent myocardial infarction and who is having heart failure. So in this category, irrespective that the blood pressure is normal or high normal, we might consider starting on antihypertensive medications as a secondary preventive strategy. Okay, so what would you start? So you have a patient, you made a diagnosis of high blood pressure. So the initial treatment, you have three choices. You can either go for ACE inhibitor or angiotensin receptor blocker, or you can go for a calcium channel blocker or a thiazide diuretic. So several years back, we had this ABCD thing where we thought either a ACE inhibitor or ARB, a beta blocker, calcium channel blocker, thiazide diuretic. But now, beta blockers are no longer recommended as initial therapy. So unless there is a compelling indication, which we will discuss briefly in a while, beta blockers should not be started as the first-line antihypertensive treatment. So you have a good choice, either ACE inhibitor, a calcium channel blocker, or a thiazide diuretic. If you take the grade 1 hypertension, your blood pressure is just above normal. So it's 140 to 159, diastole is 80 to 90 to 99. So in younger patients, you can consider starting on a monotherapy with an ACE inhibitor or angiotensin receptor blocker. And in older people, you can consider calcium channel blocker as a first-line antihypertensive medication. But if your patient has type 2 diabetes, irrespective of the age, in all ages, the first line you can consider ACE inhibitor or an angiotensin receptor blocker. So this is in grade 1, where we consider monotherapy or a single antihypertensive agent. But if the patient is having grade 2 hypertension or above, say your blood pressure is more than 160 by 110 or 100. So in grade 2 hypertension, what is the current recommendation is that always go for a combination of two drugs from two different complementary classes at lower doses, right? So this is again something that we don't practice very frequently. What we do is, even if the blood pressure is say 160 by 100, what we do is we tend to start something like say losartan, and we tend to go for a higher doses of losartan to treat the hypertension. But now the recommendation is grade 2 onward, always start two antihypertensive medications and start from two different classes and at lower doses. Right, so they are a single pill combination or separate tablets. So this single pill combination is not currently widely available in the hospital sector, but you have combinations like losartan and HCT. So losartan HCT combination, you can start at a lower dose to treat the hypertension rather than starting a single antihypertensive agent to going for higher doses. Because if you use two complementary classes, the effect is synergistic, and that reduces the side effect profile as well. Right. So your initial choice of antihypertensive, so there are a lot of other factors. Now you have 3 drugs to be chosen, but your initial choice will depend on the presence of target organ damage, the other comorbid conditions, patient's compliance, and the cost and availability. So if your patient is hypertensive and a diabetic, always consider ACE inhibitor or ARB as a first line thing. And if your patient has asymptomatic target organ damage, say maybe a LVH, some renal impairment, or early CKD, again, your preference should be for ACE inhibitor or ARB. And in a patient who has stroke, the recommendation is to go for a thiazide diuretic or a calcium channel blocker in the first line. Then you can go for combination therapies. And then for CKD, advanced CKD, you can consider calcium channel blockers and ACE inhibitors and ARBs, but you need to be a bit cautious because advanced CKD, your ACE inhibitor and ARB might lead to life-threatening hyperkalemic episodes. So likewise, you need to sort of consider the patient's, the presence of other comorbid conditions and the target organ damage when it comes to selecting an antihypertensive agent. This is rather a hypothetical side. So what is the best pressure pill? So this is very important because, as we mentioned earlier, hypertension is largely asymptomatic. So you just make a diagnosis of a hypertension in a patient who is feeling perfectly normal. And then you start antihypertensive agents. then what happens is the patient is going to experience various side effects with regard to the treatment, right? So the patient may be adapted to high blood pressure for a long time, he's fine with it. But once you start treating the hypertension, patient may be complaining some postural dizziness, patient may be feeling less energetic, or sometimes with certain antihypertensives, patients may be having erectile dysfunction, patient may be feeling a bit tired. So what has happened was we have selected a group of people who are perfectly normal and we have started treatment and we have made them sick. So because of this thing, these patients are not going to be very compliant with your treatment. Unlike other things like diabetic patients with sort of osmotic symptoms, we treat diabetes and they feel better. So they are compliant with the treatment. But in the case of hypertension, the problem is to start with they are asymptomatic and your medications are going to make them symptomatic. Therefore, always you need to talk with the patient and explain the importance of controlling the hypertension despite they're having in the expense of having side effects. So the best pressure pill should be well tolerated. So this is the most important thing because the cohort we are treating is asymptomatic. So they should have at least minimal side adverse effects. And the second thing is it should be affordable. And the third thing is the pressure pill that we select should be a long acting so that the patient should not need to take it very frequently. So he can take say once a daily antihypertensive pill, and also it prevents the blood pressure variability. So if your blood pressure sort of goes up and down, that is again not good for the organ. So a long acting slow release antihypertensive drug would be the ideal to prevent the blood pressure variability and reduce the burden on the patient to where he doesn't have to dose himself very frequently. And finally, whatever the treatment we start should be preferred by the patient. So a well-tolerated, affordable, long-acting antihypertensive preferred by the patient is the dream, but we will try to achieve that thing, but it's not always possible. And then we discussed from the grade 2 hypertension onwards, you go for combination therapies, right? So these are the preferred combinations. So you can combine ACE inhibitor or ARB, say losartan or enalapril with a thiazide diuretic. Or you can combine a thiazide diuretic with a calcium channel blocker. Or ACE inhibitor and ARB can be combined with a calcium channel blocker. And then the non-hydropyridine calcium channel blockers, what you call nifedipine or amlodipine, can be combined with the beta blocker, right? But the other calcium channel blockers, which are called non-dihydropyridine calcium channel blockers, your diltiazem or verapamil, should not be combined with the beta blocker because that can give rise to significant bradycardias or heart blocks. And again, the combination of ACE inhibitor and the ARB is also not recommended. This is again sometimes we see when patients come, they are on a large dose of losartan and the blood pressure is not controlled, so they have been started on enalapril on top of that. So it is again very dangerous because it can give rise to severe renal impairment and life-threatening hyperkalemia. And then when you combination of long-acting drugs will give the best smoothness in the blood pressure control. And it buffers excessive blood pressure control over 24-hour period. So ideally, if you choose a long-acting combination of drugs, that will have a smooth blood pressure control effect over the time. So now, this is the same patient that we are talking who has come for the first time to the clinic. So you have assessed the patient, you have made the diagnosis of hypertension, and you have met all your aims. You have identified the target organ damage and the cardiovascular risk, and then you have started the patient on treatment. And then how do you follow up this patient? So the one important thing is you should see whether the blood pressure is adequately controlled. So what we can introduce to the patient is a blood pressure diary, because we can't see the patient in a daily basis or a weekly basis. So we might see the patient maybe in 2 weeks time or a month's time. So during that period, you can ask the patient to get his blood pressure checked either at home or from a nearby place to maintain the blood pressure diary, so we can get an idea what's happening to the blood pressure, whether there are any excessive fluctuations in the blood pressure, etc. And then during the follow-up, we can do basic investigations like serum electrolytes, kidney functions, and then hypertensive patients at risk of developing diabetes, dyslipidemia later in their life, so they need interval monitoring of their sugars and lipids. And always make a habit, whenever you see the patient, reinforce lifestyle changes. So always ask about the diet, tell about salt, and then promote exercise. So these are very simple things that we can do in every clinic visit to reinforce lifestyle changes, because they do have a significant effect on your blood pressure control. This is the biggest problem that we will have. So whenever we see the patient, the blood pressure is always high in the clinic. Right, so the commonest thing what we would do is the patient comes to the clinic, we check, make a blood pressure reading, and it's 100, say 70 by 110. Then the next immediate question what we would ask is, have you taken your morning antihypertensives? The commonest answer would be no, because I came early in the morning, I have not missed I didn't take my breakfast, so I skipped the morning antihypertensive. Then we feel sort of relieved, okay, his blood pressure is high because he has not taken the medications. He put an arrow, not taken morning antihypertensive, so we sort of take it for granted. But that is the biggest problem when it comes to poor blood pressure control. There has been a recent study as well, and that study has identified the clinician's inertia is the biggest problem to have hypertension-related complications, because we have a wait and watch policy. When the blood pressure is slightly high, we think, okay, you must have rushed into the clinic, and we didn't measure the blood pressure in the proper way. We just check the blood pressure, and then patient has not taken the morning antihypertensives. Likewise, we give ourselves sort of excuses not to escalate the treatment, and we continue the same medications, and patients have a continuous high blood pressure, which adversely affect the organ. So this is something that we need to think. We have to, I mean, maybe in one clinic visit we can advise, okay, next time definitely it doesn't matter you miss your breakfast, but take your antihypertensives and get him to rest for a while, and then you recheck the blood pressure. You adapt some form of strategy, and then we get rid of this clinician's inertia to treat hypertension. So we should be proactive. We should be sort of enthusiastically changing or titrating the antihypertensive medications, because earlier we discussed the targets are not 140/90. The targets are even lower, right? So having a blood pressure of 150/100 or 150/95 in the clinic, although looks fairly okay, it's not okay. So you have to go for a lower target. Always try to look at the patient's drug chart and to up-titrate the medications accordingly. And non-adherence is another problem, because as we discussed, we treat asymptomatic cohort and we make them symptomatic, so they tend not to take their medications. And then the patient may be on other medications that can cause hypertension. So patient may be on steroids, or patient may be taking a lot of NSAIDs, maybe recently started on oral contraceptive pill, or patient may be having on taking some other recreational medications. So you have to look into that. And then excess alcohol, substance abuse, excess salt intake, all these are possible reasons where you always need a high blood pressure in the clinic. And then white coat hypertension is again something. So if you suspect white coat hypertension, the best thing would be to go for a home blood pressure or ambulatory blood pressure monitoring. And then there can be secondary causes. Sometimes the hypertension causes CKD, and with the worsening renal functions, you tend to have persistently elevated high blood pressure. And finally, if you exclude all these causes for poor control, there is a category which can have what you call resistant hypertension. So by definition, resistant hypertension is where the patient is appropriately following all lifestyle measures. So he is taking a low salt diet, he's doing a lot of exercise, and then he's on 3 antihypertensives. And one is the thiazide diuretic, and he's on 2 other antihypertensives from different classes at adequate doses. All these criteria need to be fulfilled before you make a diagnosis of resistant hypertension. So say, for instance, we have a 60-year-old man who is very adherence with the lifestyle measures. He's on HCT, and he's on losartan and amlodipine, all adequate doses, but still, and he's been very compliant with the medications as well. But when you check the blood pressure is say 150/100. So in that instance, we can make a diagnosis. Okay, he's on 3 antihypertensives, all lifestyle measures, blood pressure is resistant to treatment. So that is the instance where we make a diagnosis of resistant hypertension. Right. So then this slide will talk when to refer a patient to a specialist. So basically, I was mainly focusing at the clinic level, where you manage the patient even as outpatient with high blood pressure. But if you suspect a secondary cause based on the history, examination, or your investigation, Say for instance, there is a patient who has high blood pressure and having persistent hypokalemia. Potassium is always 2.5, 2.6. So you might think, okay, there could be a secondary cause, something like primary hyperaldosteronism, where you need to refer to a patient for specialist investigations. Right, patient might need a imaging of the abdomen. Patient might need some renin-aldosterone ratio, something like that. So patient needs a specialist referral. And then the patient has hypertension and there is evidence of target organ damage. So patient has proteinuria or impaired renal functions, heart failure, etc. So patient needs to be managed in a specialist unit. And also patients where you diagnose young hypertension. So a 25-year-old boy where you make a reading of a blood pressure of 180 by 100. Just starting amlodipine at a clinic level is not the right thing. So this patient needs to be investigated for a possible secondary cause. So the patient need to be sort of further investigated. And then the resistant hypertension. So lifestyle measures, 3 antihypertensives, optimum doses, blood pressure is not controlled, need to be further investigated. And if you suspect white coat hypertension or masked hypertension, where we might have to arrange the ambulatory blood pressure monitoring or home blood pressure monitoring, might need a referral. And sometimes you start treating the patient, you start amlodipine, patient gets leg swelling, and then you switch to another medication, he gets some other complaint. So patient is not tolerating most of the first-line antihypertensive medication. So in that sort of a case also, we might have to think of referring this patient to a specialist unit. Or I mean, obviously, it is here like in a tertiary care unit, this patient needs to be further evaluated and managed. Right. So that brings to the end of the presentation. So here actually I did not touch the hypertensive emergencies because it's another big topic. So I just wanted to focus when you see a patient for the first time with high blood pressure in your clinic, what are the basic things that you should be doing and what are your targets and the initial management of high blood pressure, and then to how to arrange the follow-up for this patient. And if the blood pressure is not controlled, when to consider to get senior opinion or the specialist opinion with regard to blood pressure control. Right? Okay, so that brings to the end of the presentation. And if you have any questions, I'm happy to answer. Yes. 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 Yes, the thing is, prazosin is something that we do use in our practice, but the thing is, prazosin has a lot of other side effects. So prazosin can cause severe first dose hypertension, and so that may not be very effective in patients. So thiazide diuretics is a very good drug, but you need to be a bit cautious. Patient need to be advised, and you have to select the appropriate category of patients. Particularly thiazide diuretics don't act when there is some form of renal impairment because it needs to, I mean, you need normal kidneys for HCT to work, right? And the other thing is if the patient has a history of hyponatremia or if he has a borderline sodium level, then again you have to be a bit cautious. But in other groups, starting a low dose thiazide diuretic is very effective in blood pressure control. So particularly this combination of losartan and HCT, that is shown to be very effective to get the blood pressure down. And these two classes, they work synergistically as well. So you don't have to go for 25 milligram, even the losartan 25 with HCT 12.5. That is what the combination tablet carries. So you can start that, and then you can actually go for a fairly good blood pressure control. Right. So always consider the first line antihypertensive medications when you think of a treatment, and this prazosin and then things like spironolactone, they might sort of affect the further investigations as well when it comes to a secondary hypertension or a hypertension. So they need to be sort of kept not as the first line treatment. Yes, in our setup, that's an indication because one problem is if the very high blood pressure is very high, but patient does not have hypertensive emergency, right? So the two options is, I mean, if we talk go through the guideline. If there is no hypertensive emergency, what that recommends is to start the patient on oral medications and to arrange a follow-up. But in practical settings, this follow-up is not practical always, because in our clinic setting, we will have a clinic say once a week, or sometimes patient might get defaulted. In that sort of a case, if the blood pressure is say 220 by 110, it is important that if the patient is not a sort of a reliable patient and you think the patient might get defaulted, etc., then patient can be admitted for gradual reduction in the blood pressure. Because we have seen few instances where patient was having a very high blood pressure and was started on multiple antihypertensive medications, say high dose of losartan, nifedipine, prazosin at the same time, and discharged to the community. And then there were few patients who have come with significant drop in blood pressure and having watershed infarctions in the brain. So in this sort of a scenario, that need to be sort of individualized. So sometimes if the patient is a reliable patient and if the patient can have a follow-up, if the patient can get his blood pressure checked, maybe next day and the day after, you can start the patient on a low dose antihypertensive and gradually titrate it in the community level. But if you think the patient might not turn up and if the patient might be defaulted, so in that sort of thing, the prudent thing would be to get the patient admitted at least for 24 hours for gradual control in blood pressure. And then you can do the assessment of the end organ damage as well in the admission, and then you can discharge the patient. So it is, I can't give a clear-cut answer for that because it depends on the patient and the social factors and the facilities available in the practice or in the hospital. Yes, that of course depends on the half-life of the medication. So say for instance, if you take drugs like amlodipine has a fairly long half-life. So even though we commonly dose it as a VD dose, amlodipine is a once daily medication. So the important thing is to avoid excessive fluctuations of the blood pressure. So what we can do is if the patient is on multiple antihypertensive medications, the long-acting medications can be obviously can be given at one particular time of the day because the action lasts for nearly 24 hours. But if there are short-acting medications, then what we can do is we can space it out according to the blood pressure response. That is why sometimes having an ambulatory blood pressure or a home blood pressure monitoring with multiple blood pressure readings, we can understand what happens to the blood pressure. So in that case, according to the blood pressure readings, we can space out the medications. So that spacing out is mainly applicable for the drugs that have a shorter half-life. Drugs like amlodipine, perindopril, they have fairly long half-life, so they can be once daily dosed. Any other questions? Okay, so in the absence of questions, I would like to thank the KSM again for this opportunity and hope you have gained something with regard to hypertension. Thank you.
Thank you, Chamara, for that wonderful, very comprehensive lecture. I'm sure that most of the PG trainees of the maximum benefit of this lecture. And thank you very much, Chamara, once again, because with a very short notice, you accepted this lecture within 1 week's time. And all the participants, thank you very much. And today's our sponsors, Pharmaceuticals, thank you very much for sponsoring this lecture. And I cordially invite Dr. Chamara Kanandar, Senior Consultant, to give a certificate and token of appreciation to Dr. Chamara. Thank you very much, madam. And the notice, all these lectures are available in YouTube, so you can Google it. And the refreshments are provided. Yet another answer to your question, Dr. Dalugama, the reduction of blood pressure is very high. Yeah, having emergency department, a lot of patients are coming with high blood pressure. Probably, as Dr. Chamara told, they usually they don't take morning dose, so the blood pressure would be about 200 and 180, but there should be a gradual reductions. If you reduce the drastic reduction, it lead to the watershed infarction. You have a lot of experience. So there are guidelines, 25% reduction and 10% reduction. It depends on the patient's endocrine damage. Thank you very much, and your refreshment will be available.